introduce myself. My name is Naomi Dreisinger, and I work at in a pediatric emergency department in the New York City area. But I studied ethics, and that's really where I focus my my speaking and my research and all of those ideas. And so I wanted to just bring a little bit of ethics to this conference. Please let me know. Can you see the presentation now? I get a little bit anxious with Zoom because I never know what people are seeing. Okay, so what we're going to do is we're going to talk about consent in the pediatric population. And what I've realized as I was listening to the conversations and the discussions yesterday and the presentations is that we are all over the world, and therefore consent is significantly different all over the world than it is in the United States. And so unfortunately, I believe that my presentation focuses somewhat on what goes on in the United States with regard to children and either parental consent or the children's own consent. And I would love it if at the end, I'll try to save a little bit of time if there's, it would be possible for us to speak and try to understand everybody's different cultures, although I don't know that this is going to be the right kind of forum for that or if we're going to have the time. So I'm going to do this as a case-based presentation, just so we have some stories and some background. And if there are any questions or anything, certainly please interrupt me. Okay, so as a definition, informed consent is a communicative process of sharing information with patients, assuring their understanding of the information, and asking for their permission to proceed. So informed consent in general, we ask the patient to give permission. Yet in pediatrics, it's a little bit different because really we're going to have to focus on the parent in most instances because the child is often not capable of consent. Now, the concept of when a child can consent for a procedure or for a situation, I think probably differs country to country. In the United States, officially, that age is 18. So the age of consent is 18. But there are different situations where we accept different ages, and it all depends on the circumstance. And I am going to speak a little bit about that as well as some of the ideas of when might a parent not be the one who's consenting and when might the physician take over this responsibility. And it is a huge responsibility to have to be the one that's consenting for a procedure when it isn't the parent. And we do hope that, most physicians understand the magnitude of this responsibility. Okay, so a physician has a professional responsibility to respect a patient's autonomy. In other words, in the United States, and I believe this is true across the world or in most places in the world, the patient is the one who makes decisions for themselves at this point. There are some cultures where the physician is still given more of the upper hand, but certainly in the United States and many of the Western countries, I believe we defer to the patient more often than not, which has its difficulties, especially nowadays. But it does allow the patient to use their value system to help them decide whether or not what we're recommending is correct for them. And so in pediatric populations, who consents? So as I discussed earlier, often it's the parents. In a situation where a parent isn't available, it might be a guardian or somebody that has been given permission. And then when it comes to the patient, well, when can a patient actually consent? And we said that in the United States, that would be 18. But what about assent? Is there ever a situation when a parent can actually, when a patient can agree and say, yes, I want this, even if their parents don't want the recommended treatment? And then there are certain situations where the physician, the doctor will step in and have to behave as the parent in welcome parentes. They have to take the responsibility upon themselves and assist in making the child's decision. And we're going to try to speak to some of these in this discussion. So the first discussion is a little bit complicated because I do believe that this one is significantly different around the world. And even nowadays across the United States, each state differs because of more recent political situations that have happened. So a 15-year-old girl presents to the emergency department and she's accompanied by her father. She complains of burning and discomfort on urination. And when questioned alone, and so we do try to do that. I work in an emergency department, but I imagine in doctors' offices, the same thing is done. Once a child is of adolescent years, often we'll ask the parents to leave the room and we'll have a discussion with the patient by themselves so that they can feel comfortable and ask questions that they want to ask. So the patient reveals that she is sexually active. She states that she has pain and discharge to her vaginal area. And on pelvic exam, the patient is noted to have vaginal vesicular lesions compatible with HSV. So what's our responsibility to this patient and to her father? How do we approach this exactly? Because we need to make sure that this child, and she's still a child, she's only 15 years old, sexual activity doesn't make her any more mature. We know that. But what is our responsibility? Do we have to tell her father so that we know that she takes her medication, that she's treated, that she doesn't transmit this sexually transmitted disease to other people? It's a little bit frightening, but the reality is that in America, in most situations, a child who is sexually active is entitled to privacy and to autonomous decision-making, meaning that I can tell this 15-year-old girl her situation, explain to her the appropriate treatment, review all the important course of action with her, and not share with her father at all, which I know is not necessarily the right thing because she might not follow through upon it, and she might not understand the intensity of the whole situation, and she might not take it as seriously. So often what I will do is I'll say to the child, I'll explain her the whole situation very carefully by herself. I'll explain to her the complexity of it, and I'll discuss with her the importance of sharing with an adult. And sometimes it's not going to be a parent. Sometimes she'll get an aunt or somebody else that she feels she can trust on the phone, and we can speak about it. But having any adult involved is often very important. Yes, we have to tread very, very carefully, because in actuality, I don't have a responsibility to her father in this situation. I have a responsibility to make sure that the child is treated and to make sure that she follows through with her treatment appropriately. Okay, so when can minors consent? Because we just said, here's a story where a child comes in and she has a situation, and I'm not going to share with the parents this situation. So number one, it depends on the type of treatment that the patient receives. Number two, it depends on the status of the adolescent. So there are adolescents who get married before 18 or who become pregnant before 18. And in those situations, they become the autonomous individual and they become the person that I would speak to, not the parent. Then it depends on the medical circumstances in which the patient is seeking care. So similar to number one and the treatment, but a little bit different in that there are other medical circumstances where we might involve the patient, the child, more than the parent, and that has to do with chronic situations, and we'll try to talk about that a little bit later, although I don't know if we're going to have time for that. And then, of course, where the patient lives. So if the patient is actually an autonomous individual, so let's say this is a 17-year-old patient who lives on her own, who supports herself, in the United States, that patient can make her own decision. Now, why is it so important for us to give these adolescents the opportunity to answer for themselves, to decide for themselves? And so in the United States, we have an institute called the Guttmacher Institute, and they study these things and they try to understand what's going on with sexually transmitted diseases, what goes on with pregnancy and abortions within the United States. And when is it important for us to allow the child to decide, and when must we involve the parents? And so they've done studies, and basically 17% of adolescents would not even seek any medical treatment if their parents knew, because they would be afraid that they would react to it. 15% of adolescents would seek STD treatment if they had to inform their parents. That's a tiny number. And 65% of adolescents would seek medical care if assured of confidentiality. And that's very, very significant. And so we have to understand that it's very important for adolescents to trust their physicians and to turn to their doctors as a voice and for help. And if they can't do that because of their culture or because of their parental involvement or just because it makes them uncomfortable, then we hesitate and we say, well, we need to make sure that the child is being treated, and we need to make sure that that everything works out for this child who's going to then become an adult and move into this world, and we need to give them trust in the medical system. And so it's a very emotional and important subject, certainly now within the US climate with regard to abortion, but certainly all over the world. And I think it's very, very complex. So back to our case. So I think we answered all of these questions already. Can this patient be examined and treated without parental consent? Well, the answer is yes. And our full responsibility is to this patient and not to the patient's parents. Although it becomes very challenging for the physician because we can't lie to the parent, yet we have to be very vague about the information that we're giving to them. We then have to be very, very cautious with regard to the papers that we hand to them or the access with charts. And all of this is very complex. We're very lucky. I live in New York State and work in New Jersey, and both of our states have mechanisms created to help these adolescents so that they can gain what they need. And to me, that's very significant and very important. Okay, so we're going to move to the other side of the pediatric spectrum, and we're going to move to infants and small children. This is case 2. So new parents bring their 2-week-old infant into the emergency department. They report that their daughter has been having a fever since this morning. They had called their pediatrician, who recommended that they bring the baby into the emergency department for evaluation, which they did. At 2 weeks old, a baby who has a fever generally will require a full fever evaluation, which is very scary to a new parent who's never had to have anything done to their child. You know, they brought them home and all was good. And so when they hear about what's going to happen, they get very anxious and start wrapping their baby up again, tuck her back into the car seat and say, well, you know what, forget it. We'll just take her home. We don't want you to do that. And you say to yourself, well, what's my responsibility in this situation? Because I'm not doing this because I want to stick needles and cause harm to this child. I'm doing this because I'm very concerned that there's some kind of infection in this baby that could be missed, and the baby could get very sick, become septic, and die. And how do we manage that? How do we approach it? So I'm sure that many of you have had similar situations where you explain something to a parent and they balk at the concept. They're not comfortable with the idea of moving forward. It's frightening to them to do procedures on their child, and they get very anxious about it. But our responsibility is to the child. And one would hope that as a physician, we do what's best for the patient. And so we have to very carefully and slowly explain that to the parents and encourage them in the right direction before getting angry at them or aggravated with them that they're not understanding what's being said. And the question really is, how do you do that? Because often we're in a high intensity situation. Certainly in the emergency department, time is of the essence, and we want to get things done. We want to make sure that this baby is treated appropriately. We want to admit the baby to the hospital. We need to do, blood cultures, urine cultures, spinal tap, potentially other tests. And we need to give this baby some antibiotics and get moving to make sure that the baby is well and healthy. Yet parents get anxious about it. So often what I tend to do is I'll go very slowly. So I'll start by explaining to them what we need to do and why we need to do it. We'll start with the blood, we'll start with the urine. Those are more benign procedures to a parent. It's often the spinal tap that makes them very, very uncomfortable. And in situations where it's needed, I'll actually get their regular doctor on the phone. Now, the downside of an infant is that often the parents don't have very much of a relationship with their doctor yet. They've barely met them, maybe met them once. But even so, sometimes just having a somewhat familiar face, somebody that they've chosen to trust, rather than a doctor in an emergency department that they're only meeting at that moment, is helpful. And having a discussion, even bringing in colleagues who can encourage them that this is the right way to go, that this is what we have to do, is often very, very helpful. But the truth is that when it comes down to it, we have to treat this baby, and it does fall to the physician to insist upon it. I have never had to call in authorities, but I do have colleagues who have had to call in. We have in the United States Child Protective Services, people who will come and make sure that things are done properly. I prefer not to do that, and I've always found that if we speak to the parents and we guide them through it carefully and slowly and make sure to answer all their questions, they do end up agreeing, because often they're just afraid and they just need a little bit of assistance. Okay, I think this is my last case. So you are the primary physician of a 17-year-old patient who has had ongoing treatment for acute lymphocytic leukemia for the past 10 months. Recently, the patient has felt increasingly fatigued, and yesterday's CBC revealed a hemoglobin of 4. The patient and her family are Jehovah's Witness. Jehovah's Witness are people who don't accept blood transfusions, and so the family has refused blood transfusions for this patient. But today, the patient motions you to the side and says she'd like to speak to you without her parents present. Yes.
Doctor, we couldn't able to see your screen, doctor.
You couldn't see it the whole time or just now?
The whole time, doctor.
Oh, I'm so sorry. It
Yes,
doesn't
sir.
say very much. Can you hear me
Yes,
now?
because, yeah, I could hear you.
Okay, so I'm going to finish because I only have 5 minutes left, but I don't understand why you couldn't see it, and hopefully I'll fix it for my next presentation.
Okay, doctor, thank you.
Okay, thank you. The patient, where were we? So the patient motions you to the side, and she says she'd like to speak with you without the parents present. And she quietly says to you that she's tired and she would like a blood transfusion. So the big question becomes, what do you do? Are you allowed to give it to her? She's only 17 and the parents are saying no. And it's an interesting question. In the United States, this is a question that ultimately would have to take to a court of law in order to get permission to and allow this 17-year-old to assent to her treatment. But the reality is that ultimately a 17-year-old with an illness such as ALL, where she's been receiving medication for a prolonged period of time and she understands the severity of her illness, we can defer to her. With, of course, careful explanation for the parents. And so the big question is, at what age does assent really factor into consent? And that's a challenging one. Basically, once children are beyond the age of 14, we start to consider whether we can accept their assent. And usually it requires a psychological evaluation to try to really understand what it is that's going on.